Okay. And I think we should get started. And if more folks jump in after we're started, just because your time is so limited, Paul, and we appreciate you giving us your time. So
No problem.
um, thanks to those of you who could join us today. We have Paul, is it Homitz-Daniels with
Yes.
us? Okay, he's a board certified adult gerontology nurse practitioner, and he earned his master's of science in nursing from Case Western Reserve University's Francis Payne Bolton School of Nursing. Paul has years of experience in cardiovascular, critical care, and emergency psychiatric, addiction inpatient management, along with geriatric psychiatric care. He's certified to treat adults and adolescents ages 13 and older in both outpatient and long-term care settings. Paul is also certified through NESTA or NESTA as both a lifestyle and weight management specialist and a fitness nutrition coach. His approach to care of his clients is to integrate medical knowledge and nursing care in utilizing pharmacologic approaches to complement the behavioral therapy offered at PBHS, which is Premier Behavioral Health Services, which we are so grateful for their support of NAMI Lake County to promote the best possible treatment outcomes tailored to the individual. Thank you for being, that was all a mouthful. Thank you for being with us, Paul.
You're welcome.
I appreciate you.
Sums it up pretty well. And I want to say thanks you to NAMI for all the support groups and other services that you provide for people in the area. And it's a valued resource. So yeah, thank you very much for that.
All right, the floor is yours, Paul. I should say also, Paul's time is limited with us, but after Paul is done, we are also going to hear from Carl, who has lived experience in this area, and I'm the Jamie from NAMI Summit County, which we're so thankful for their support. She's going to take the time to introduce Carl because she knows him much better than we do, and we so appreciate his time as well. So whenever you're ready, Paul, go ahead and start informing us.
The tardive dyskinesia. I mean, there are two different. I guess they're not different. They're somewhat interrelated, but TD or tardive dyskinesia is movement disorder that when we hear different figures, it probably affects about 600,000 people in the United States. Mainly, it's a mainly related to antipsychotic use, dopaminergic medications that affect regulate dopamine. And then so there are risk factors for it, of course, taking a psychotropic medication that is dopaminergic. Uh, Typically, the tardive dyskinesia symptoms onset it takes a long, well, not a really long time, but it could take a few months to few years. It's harder to reverse the effects. Sometimes the effects are permanent over time, and it's really hard to change that. However, there are some newer medications that do help um, reduce the symptoms, make them more manageable. There's a difference between the medication-induced Parkinsonism, which is more of the rigidity, bradykinesia, slow movements, versus the tardive dyskinesia, which is oral, like most common symptoms that people would notice of the oral facial dystonia is loss of motor control with facial muscles and other, more of on the um, akaesthesia, uncontrolled movements that way, not whereas the EPS is the slowing down, like Parkinsonism. Sometimes hard to distinguish between the two, which is why you would many times get a neurological evaluation. But the tardive dyskinesia tends to develop long, is harder to reverse, and doesn't always improve when you reduce the dosage of the medication that has been causing the symptoms, which are mainly the older types of dopaminergic medication, Haldol, thioridazine, fluphenazine, perfenazine. But newer medications could also contribute to these symptoms. The percentage of people that usually they record as experiencing these symptoms, probably about 25 to 30% after like 5 years with the medications. So a significant percentage. And as I said, it's difficult to treat sometimes those symptoms to reverse. Newer medications have been more effective. I guess I look at overall with the number one thing with the symptoms is maybe to look at their prescriptions, and if they don't need an antipsychotic medication that would negatively affect or contribute to the tardive dyskinesia, then is that necessary, or can we reduce the dose? Like I said, it doesn't always help to reduce the dose if they've been on the medication for many years. But you always look at that first, like, is that needed? Or when you're starting treatment, you don't go to that medication unless it's really needed. And some people with symptoms, mood disorders, or symptoms, bipolar disorder, schizoaffective disorder, really to be able to live their lives, they do need some type of treatment. It's just always trying to figure out what to fine tune it. What's the best way to do this? If they need to, sometimes they respond to one medication better than another overall. They might develop the TD, but then there are some newer medications, mainly the VMAT inhibitors, like Austedo and Ingrezza, that could be used to help with that. So bottom line is you try to minimize, I guess, number one, you try to minimize, if possible, the medication load. And then number two, you look at other treatments from the medication standpoint, other treatments that might help someone manage those symptoms better. So, and there are more options today than there have been in the past. And I will say there are newer medications that within the last few years that have a much better profile with the lack of the TD symptoms long term. Although you can't, all ads for these medications will always state that, yes, you could experience these symptoms over time, involuntary muscle movements, the dystonia. But I will say that the newer medications are a little more precisely targeted towards certain receptors, so they don't get that collateral effect, which I guess you'd say causes some of these other unwanted symptoms. So that also has improved. So you try to look at that as well from the medication standpoint. And then, of course, other support therapy does help as well. I know that I think there's a national organization for TD, National Organization for Tardive Dyskinesia, that does offer online services, and they have some information videos concerning TD. So that might be helpful for some people too. So I think that it's been improving as far as the treatment, but it still can interfere with someone's ability to function. And you always look at ways to help with that, as I said, adjusting medications or adding something that could help them manage the symptoms, maybe not eliminate the symptoms, but manage it better, basically.
So, Paul, are you open to answering some questions?
Oh, yeah, I was
Because
going to say, if you have a question, sure, yeah. Go
I
ahead.
see a hand raised over here. So,
Paul, can you hear me okay?
Oh, sure, I can hear you fine.
Okay, so I have a question. You mentioned there's about 600,000 people in the United States. Are you seeing that trend increase or decrease? Or is there any indication of that?
I don't know if it's really increased. I suppose there might be some increase there with more, I think over time, just with the population, more people being treated. You do have more higher risks with age 55 years or older. Also, postmenopausal women, history of substance abuse, and like I said, mood disorders. That's your risk factors for it. But yeah, I'd probably say there's been some increase. I don't know exactly what the data shows from. I don't know if they recorded it as much years ago. Maybe I don't think that they had that much data that they kind of estimate maybe how many people are on the medications and then what percentage of those would develop the symptoms.
Was my other question. Well, one of my other questions, because you mentioned that about the data being tracked. I mean, how long has this phenomena been monitored or really addressed over the years?
I would say probably only within the last. I mean, they've known about it for a time, so I'd have to say the last few decades. It's been a term, tardive dyskinesia, and then the extrapyramidal symptoms, which is a separate type of range of symptoms, but that's been known for. Oh, maybe it's probably in some way, shape, or form since they started with these medications, the original ones back in probably the 50s, late 40s, 50s, when Haldol, tioridazine, and tioridazine, and then prevented, like it's that class of medication, the original, the original antipsychotic medication. Then as more and more people were prescribed the medications, then that's why I imagine it was just a few years after that. And then they came up with the term for it probably a little later than that.
It's been around since the 50s. Um, so I have one last question for you. What is the evaluation process for determining whether somebody has PD or not? Like, what does that process
Well,
look like?
yeah, you can do in office like the AM scale, the involuntary movement scale is also what they call the discus scale, which they say is sometimes better for isolating the symptoms or being able to diagnose tardive dyskinesia in particular. And then also, you might want to look at a neurologist and have neurological exam and assessment to rule out other causes for it. I know with the drug-induced Parkinsonism, yes, you have to rule out, Parkinsonism, Huntington's chorea, or something, those types of diagnosis that might be overlap with the symptoms. But generally, you can't, based on someone's history, the patient's history, you can, see what the medication history has been, and then you could basically, yeah, do the scale, and then you follow up on the scale every few months after that, and see if there's been any improvement. You can add in, like as I said, some of those medications that can help mitigate the symptoms, and then follow up from there. But for a more detailed is a baseline assessment, full neurological assessment might be needed in some cases.
Okay, great. Thank you very much.
Sure, you're welcome.
So I have a quick question too, Paul. So you noted that it was really like the older drugs that are make people more prone to having the tardive dyskinesia. So are the newer classes of drugs, is that something that, is it lowering the risk for that or no, it's still having kind of the same?
Well, it depends on, I would say I guess you call it second generation of medications after the initial one, which were, as I said, began in the 50s. And then there were ones after later on. But I think they reduced the risk, but did not eliminate it because you still see the symptoms happening in the second generation medications. Now, I guess you call third generation or whatever are different because they take a different approach. Like there are some newer, like Caplyta or Cobenfy, they work in a different way, have a different mechanism of action. So they tend to, especially Cobenfy, which is, I think it works mainly with muscarinic receptors. And they found that did help with managing bipolar schizoaffective disorder without really any chance for any movement disorder developing the way it works. It's just, it revolves all around the dopamine, too much dopamine signaling in the brain. And as I said, hard to reverse. But I say, yeah, the second generation and third generation, I guess you call it, would be better in that there are less of the stray collateral effect, you'd call it, more precise with the way they've developed the medications to hit certain receptors, agonize, antagonize certain receptors versus just everything, and then more targeted, which then helps to reduce the symptoms, I think. So some improvement as you go along, more improvement, I think, with the latest medications. So yeah.
Mhm. Thank you.
You're welcome.
Does anybody else have any questions that you would like to ask Paul?
Paula, one thing, just a thought, not a question, just a thought.
Yeah.
600,000 population in a country with 360 million. I think that's our population, or 330 million or something.
Yeah.
Doesn't seem to be such a large population. But boy, I'll tell you, what a disabling um, challenge to have. And it's just great that the somebody's giving it some attention, like the drug companies, in order to be able to help solve this problem. That's just an observation. Because when I look at the population, it's not a significantly large population, U.S. part of the U.S. population. I mean,
No, I guess considered as a percentage of the people that are prescribed dopaminergic medications. Well, that might, overall, there might be a couple million or more people that are 3 million or more people possibly prescribed the medications. It's possible it could be underreported too as well. But yes, you're right. It's very limiting in many ways and hard to manage and not always reversible. I've had some cases where, yeah, it was completely reversible, but others will experience these symptoms and they linger and they do interfere with your daily ability to function well. And but the newer medications I've found have worked. Of course, any medication that you prescribe, including the ones to help control the symptoms, can have side effects as well. So that's another thing. You always have to look at that and get the right medication. Those aren't the only ones. There's some other medication like amantadine, which is an antiviral medication that they found works, does help. And the other medications you use for extrapyramidal symptoms, like I said, the slowing down part of it, like Parkinsonism, uh, the anticholinergic medications usually are not recommended for use in tardive dyskinesia, but sometimes I found that they do help some people, but it's generally considered, you don't use those. But yeah, so it's a lingering issue. It's always that thing of you want to help control the mood symptoms, but then the side effects can't outweigh the positive benefits of medication. And you always do try to look at lowering the medication load. I think is the number one step, if possible. Yeah.
I'm interested in hearing from Carl on the quality of life implications. Is
Oh yeah.
that it seems to be like they could be relatively high or catastrophic in some cases.
Hmm. Oh yeah. Very limiting. Yeah, and it persists and it can cause other mood symptoms too, related to experiencing those symptoms and having it interfere with your functioning and limiting you and a lot of things that you want to be able to do, but you're limited by the symptoms, and that's not good. And that's what you look at. The medications to help, not, as I said, not eliminate that, but some of the newer ones can help. And I would say with cost too, they've been pretty good with most of them with support. If someone doesn't have insurance or the coverage is not great, they do find some ways to have these support solutions for people to help them
Good,
be able to get the medication at a more reasonable cost.
good. Thank you.
You're welcome.
So you mentioned, Paul, that it's challenging, well, it's limiting. Can you expound like on your, interactions with your patients? How is it limiting? Like in what ways? And just in general, obviously, but how does it affect quality of life, things like that?
Well, just I think a lot of it's just the awareness of the symptoms, and you become aware of the repetitive motions, especially like oral facial dystonia, and become more self-conscious. You might socially isolate more because of that, or it could also be just some coordination problems with the symptoms and not feeling comfortable. But a lot of people sometimes end up not feeling comfortable getting outside of their home environment, or just feeling more self-conscious with the symptoms that persist and don't seem to improve over time. So, yeah, it's limiting physically and mentally, really. Yeah, and also it's not totally limited to the dopaminergic medication, antipsychotic. There are some older tricyclic antidepressants, and even I think Prozac and Zoloft have been linked to it. Not as severe the symptoms, but they do that sometimes for some people, and I have seen that in a couple of cases, will cause some muscle rigidity or loss of control. That's pretty rare with those medications, but it is possible. And of course, with Parkinson's disease medications like levodopa and phenobarbital and some other ones too. But yeah, and as I said, it's not always you stop the medication and you bet sometimes when you're lowering the medication, if you want to take that approach, the symptoms could become a little worse. So that's also a tricky thing too. But yeah, it's very limiting. Like the frowning, like it doesn't, you can't express yourself because people misinterpret what your facial expression, that like tongue, like sticking out your tongue, frowning, grimacing, lip smacking, and that. So people will misinterpret that, and that'll cause a lot of problems too. And the way people are perceived that have these symptoms. Yeah.
Thank you.
You're welcome.
So, we have just a few more minutes with Paul. Is anybody, I just want to, make sure I leave the floor open for anybody to ask their, last burning questions before Paul has to head out to serve our community members. So,
Well, I don't have a burning question. I just want to say thank you for joining us. We're a group of peers, right, that supports other folks with mental health concerns, and having this knowledge is so important. And just like you have to keep up to date with your knowledge base, we have to as well, so we're not irrelevant, and we can make good recommendations to folks to be able to treat and seek treatment. So I really appreciate your time today.
Oh, you're welcome. No problem. Glad to do it. And of course, as I said, I appreciate NAMI and all the work they do, you do there. And it's always great to have extra support resources that you can recommend to people and family and their families. Yeah, it's just you're always trying to find out, trying to determine what is best for your client, and not just throw medications at someone, but try to figure out what would be the best, what will cause the fewest problems for them, and then um, help them live the life they want to live, and not feel limited day to day by the symptom. Like the symptoms just dictate how they're going to feel that day or what they can do. Yeah, basically.
Well, as a guy who's experiencing some healthcare issues right now, some health issues, hope is a very powerful construct. If
Hmm.
you don't have hope, it can be demoralizing. So I'm glad you're providing hope for people.
Oh, you're welcome. Thank you. Thank you.
okay. So thanks so much. And
You're welcome.
I'm going to turn the floor over to Jamie from NAMI Summit, and she's going to introduce our special guest who is going to share with us his lived experience.
Well, good morning. Thanks again, Paul, for supporting our efforts to provide TD awareness. A
You're
special
welcome.
shout out to Joanna and Matt from Lake County for organizing and again wanting to move the needle when it comes to TD awareness. Have a
Thank
good
you.
day, Paul.
Thank you.
My name is Jamie Messenger. I serve as the executive director at NAMI Summit County, and I want to introduce my special friend Carl here. We have been connected since 2018, and I've always been moved by Carl's ability to advocate for TD awareness, to advocate for mental health awareness. And Carl, you just have a fabulous way of sharing your story and an ability just to advocate in ways that many others just can't. So really excited this date and time worked for Carl. So thanks again for being here, Carl, and welcome. Go ahead.
Hi, my name is Carl. Can you hear me? Hi, my name is Carl. When I first come down with the illness, one night I couldn't get comfortable to sleep, and I had a doctor's appointment coming up. So he diagnosed me with Tardive Dyskinesia. In the beginning of my situation with the Tardive Dyskinesia, I would isolate myself because people would sometimes look at me strange or funny. I wasn't comfortable being around people with the illness. My illness mostly is in my neck and my mouth area. But as it goes on, I was never a shy person. I sing in the choir and I sing with other groups. I get out in the community and try to participate in other activities that limit other people. I've seen people who have it are really, it's a debilitating illness. But I learned to deal with it along the way. I take my medication. I'm on Ingrezza for my Tardive Dyskinesia. I take 80 milligrams of Ingrezza. It seemed to help. Sometimes I see a neurologist and he put me on Botox, but the Botox was too expensive, so I had to drop that. But I learned to live with the illness. It can sometimes set you back in life, but I try to socialize and get out in the community and try to be helpful to other people who have Tardive Dyskinesia. I've seen a couple of other people who have Tardive Dyskinesia, and they don't do as well as I do. Now I learned to deal with it over the years by just getting up early in the morning and taking my medication and going for walks. It seems to help with my Tardive Dyskinesia. Some people don't do well as I do, but I've been taking medication ever since I was about 15. The doctor said I developed the Tardive Dyskinesia early in life. I'm 68 now, and I started taking psychiatric medication at the age of 15. But through all of this, I learned a lesson. Everybody has problems. They said there once was a man didn't have no shoes, but there once a man who didn't have no feet. So everybody has their own complications in life. You just have to learn to deal with your situation the best way you can. And it's helpful to me just to pick up more knowledge on Tardive Dyskinesia. I read up on some of the subjects of dyskinesia, and I've been working with Jamie for a while. And she asked me to advocate for Tardive Dyskinesia on several occasions. And I learned that if you let something put you down too long, you will go down and you'll never come up. And I learned just to keep trusting in the Lord and making my way through life the best way I could. That's all we got. Thank you.
Thank you so much for sharing with us, Carl. I appreciate it so much. I love hearing from you, and your positivity is impressive. And so thank you. I see Matt. Matt has a question for you. Matt's full of questions today,
Yes.
so he has a question for you.
I'm full of something today, let me tell you. But Carl, mine's not a question, mine's just a statement. You know, something you said is really resonating with me about how you kind of, I think this is what I heard you say about staying away from people and sort of just, sheltering and being by yourself. And I just want to let you know how powerful that message was to me today, because I've been having some hip issues and I can't walk unless I walk with a roll eater right now. And I'll tell you, I feel the same thing. Like I don't want to be around people. I just sort of want on the weekend just be in my house and I don't want to go anywhere. And it's impacting my quality of life. And that statement you gave about, having the shoes and having no feet, that was very meaningful to me. So I don't know why you were sent to do this conversation today, but it was very meaningful to me. I just wanted to thank you for that.
Thank you, Matt. Any more questions?
I have a question, Carl. So I know you said that you're taking some medication and you've been working on, like you get up early and you go for walks and you have been, keeping yourself engaged. If if you were to make, a top five list, for folks who were really struggling, say we were discussing it in a support group and you wanted to really give your, assistance, would you add anything to that list, exercise and medication, but would you add anything to that list?
Yes, never give up. Just to keep on fighting and hang in there. Everything's going to be all right. They have a lot of research going on right now. For a long time, tachycardia was in the closet, but people are coming out and recognizing it as an illness, and they doing great work with the medical profession to help with tachycardia.
That's a great it's a great message, right? You never know when the breakthrough is going to come. It could be tomorrow that something comes up and there's a tremendous breakthrough. Yeah, that's impactful. Shay, what go?
I didn't have a question. I just had a comment. I just want to thank you and I appreciate you talking about it and giving the visual an understanding of what it is. A better understanding of seeing someone and talking to someone versus just reading about it. So thank you and I encourage you.
Thank you.
And I actually wanted to say as well, one of the things that I always found concerning is the amount of people that have shared with me that they developed TD after the medication and didn't get the risks from the doctor. The doctor didn't say, hey, this is the best maybe for your symptoms, but this might happen to you in 5 or 10 years. And I know, Carl, you and I have had some great conversations around the medical portion and the awareness from the doctors. Could you touch on that just a little bit with us? Like, what was your experience like when you think about the doctors talking to you about TD early?
Well, the doctors they were kind of in the issue of they didn't know much about dyskinesia. So over the years, they have developed a way of try to present themselves in dyskinesia to people who have it. And it's been helpful to me because when I come down with it, the doctors didn't know much about it. Over the years, they're getting better at it.
Mm-hmm. Can you tell us a little bit about what it was like when you were first diagnosed?
Yes, I had trouble with speech impediment. I was biting my tongue, and I had a lot of disruptive movement in my neck and my mouth area. And I didn't like being around people.
Mm-hmm.
I shied away, I isolated myself. But I learned that you got to get out and be among people because that's what the whole network of people who can help you and you can help yourself.
Thank you. And Carl has a God-given talent to sing. So if anyone ever needs a singer for any event, this might be your guy.
We'll remember that, Carl.
Okay.
Mm-hmm.
So does anybody else have any questions or comments for Carl or Jamie? Jamie is at NAMI Summit County. Thank you, Jamie, again for, we had a few people join us. So just in case anybody didn't hear, this is with the support of Jamie at NAMI Summit County, we were able to, blessed to have Carl join us today. And so we do try to work together as NAMI so that we can We keep our community first and serve as many folks as we possibly can, and we do that by working together. And so, are there any other questions, comments? I wanted a point of clarification, if you don't mind, Carl, is you said you were 15. Now, were you 15 when you started taking psychiatric medicine, or were you 15 when the TD started?
No, I was 15 when I started taking psychiatric medication.
Okay. About when did you start having your symptoms?
Oh, it's been about 15 to 20 years ago.
Okay. All right. Okay, I'm going to give you, a going once, going twice, going three times for questions and comments. I'm not a auctioneer, but
I just
Well,
wanted
thank
to
you,
recognize.
Shay, Ashley, and Ann for being here to learn more about the conversation today. I appreciate you.
Thank you so much for your strength and courage and just sharing your lived experience. That's what NAMI's about. So I appreciate your time. Thank you.
Good
Thank
job, Carl.
Thank you.
all right.
Thanks,
And with
Carl.
that, I think we're going to wrap up. If you have any questions that come to mind after the fact, maybe you want to pass along to Paul, who shared in the beginning with us, or even to Carl, we can pass those questions along. You can email them to me, joanna@namilake.org, and be happy to get you connected with the right folks and get you answers to any of the questions that you might have, get you information. NAMI works closely with pharmaceutical companies and with providers. And so we have a great network where we can definitely get you plugged in. So, and with that, I think we'll say have a great week to everyone. And we appreciate your time. And we'll say goodbye.
Bye.
Thank you.
Everybody.